consultant neurologist, SKS Hospital, to come to the dais. Session.
Hello. Dr. Jennifer Matthew Kaur has done his MD and DNB and DM and postdoctoral fellowship. He is a consultant neurologist, Shanmuga Hospital, Salem. I request Madam to take over the dais.
I think before Madam starts, I would like to add few points. Actually, stroke is one of the few conditions where a timely intervention can matter a lot to the patient. You can give a second life or new life to the patient. It's much more aggressive. You should be much more aggressive in approaching a stroke rather than an MI, because even in MI you have a little bit more time to intervene. Whereas in stroke the time is really, really less, and I think Madam will be highlighting how much neurons will be lost if you delay by even 1 minute. Okay. So this stroke thrombolysis has been going on in Salem. We have been doing for more than 10 years now. So it started initially with Altiplase. Actually, it was an okay drug, and we have been doing it for the past 10 years, but it had certain drawbacks in that because of the cost and large vessel occlusions, wherein it's not much useful. And the major drawback with Altiplase, I don't know whether Madam has been using, she has been recently in the field. So it's a re-occlusion rate. The patient will improve on table, but within 1 or 2 hours, again the clot comes again. So after introduction of Tenectase, this is for the past 5-6 years we have been using. It's a wonderful drug, very cheap in the sense when compared to the hospital stay and future outcome, it's a very cheap drug. And it works better. Many times it avoids the mechanical thrombectomy as well. So those who come here try to understand what are the symptoms and signs of stroke and when to refer and where to refer. I think Dr. Jennifer will be touching upon this. Over to you, ma'am.
A very good afternoon to one and all assembled here. Today's topic is acute stroke management. Stroke is a common disease which we come across in our routine practice, both in the outpatient and emergency services. We need to know what is the latest guidelines regarding management of acute stroke. So I'll be briefing upon the common pathophysiology, the workup for acute stroke, and the current management policies available. Next slide, please. So this was an article which was published in BMJ in 2019, which shows that the stroke burden in India has been increasing consistently over the past 10 years. And it is a leading cause of death as a fourth in number, and a fifth leading cause of disability. When I say disability, post-stroke disability actually gives a consistent amount of financial burden to the caregivers. So there we should focus upon how to manage an acute stroke in the ER setting. Next then. So we all are very familiar about the circle of Willis right from our first year MBBS, and this is the area which I'll be covering in today's topic. But this is not all about stroke. We have another parallel circulation which is happening. Next slides, please. So what shall not be covered in my topic today is, I will not be covering in detail about the acute stroke imaging, the endovascular therapy in acute stroke, management of small vessel disease, hemorrhagic strokes, carotid revascularization, and post-stroke rehabilitation. Next slide. So we are familiar about the different types of stroke which we come across. Most of the time an ischemic stroke present in the ER, ischemic or hemorrhagic, but a small vessel disease, it usually will be an accompaniment of many of the first two types, and most of the time they can remain asymptomatic for quite some time also. So when we approach a patient regarding etiological workup, we should actually look about where there is any culprit vessel which is involved in the current presentation. So whether it is associated with a stable plaque or an unstable plaque, and whether there is a coexisting small vessel disease, are there any coexisting cardiac risk factors, modifiable risk factors like hypertension, diabetes, smoking, obesity, and other non-modifiable risk factors like age, sex, race, so these are and genetics. Yes. Next. So this is what I wanted to emphasize upon. There is a parallel circulation which is happening at the microvascular level. We have a rich anastomotic network in the superficial cortex as well as in the deep medullary level. So the pathology is entirely different from what we see in a routine practice. So this is a pathological slide which shows the actual lipohyalinosis, and it is most often found in non-malignant hypertension, whereas when a patient presents with an hypertensive crisis, the pathology usually changes to fibrinoid necrosis. These are the different imaging findings you can come across in hypertensive arteriopathy. You can have a variety of small vessel changes, microbleeds, dilated vessel spaces, white matter changes. So these are things which usually be picked up when the patient presents in an OPD or in the ER, apart from the culprit vessel which is involved. So we are very familiar with different types of intracerebral hemorrhage. Again, it can be a vascular malformation or a microvascular disease or an aneurysmal rupture. So I will not be covering on any of the first three categories. I'll be moving right ahead to the intracranial atherosclerotic disease, which is the commonest cause of acute stroke, which we handle in the day-to-day basis, and which has got much more therapeutics to be offered. So it is the commonest cause of it's a common cause of ischemic stroke and has got high recurrence rate. And what we mention, what we mean by intracranial atherosclerosis is the internal carotid arteries as they enter the petrosal bone, and the vertebral arteries as they enter the foramen magnum once they pierce the dura. So there are different mechanisms underlying in an ICAD. It can be an artery-to-artery embolism where an unstable plaque rupture and gets embolized from the culprit, from the first site into a distant location. Or it can be a hypoperfusion. We call it usually watershed infarct. It will be the affected part will be somewhere distal to the stenotic artery, or the plaque will be somewhere abetting the origin of many of the perforated branch. So this is the first artery-to-artery embolism mechanism. You have an unstable plaque which has got a rough surface, it has got an ulcerated top, and there is an accompanying stenosis on the left vertebral artery. So the plaque can rupture and can embolize and cause clinical manifestation somewhere else other than the culprit artery. Whereas in a perforated artery, the plaque is usually located near the origin, the ostia of the perforator. So most of the time, the imaging findings will give us an idea whether which pathology is ongoing during the presentation. So this is a TOS trial which actually demonstrated the location of the different vessels which are usually involved, and most of the time MCA was the commonest territory involved, and small vessel occlusion was, that means the perforator type was mostly involved in the posterior circulation territory, and cardioembolism most often affected superior cerebellar artery in the posterior circulation territory, and vertebrobasilar was compared to carotid artery, vertebrobasilar is associated with most of the small vessel disease, and multiple vascular territory one should rule out cardioembolism and large artery embolism. So this is an axial section right in the anterior circulation and the posterior circulation stroke right from the ICA, the different perforators, the main branches of MCA, ACA. One can actually get familiarized with the imaging pattern so that in the ER you don't have to waste time in the clinical localization. Again, coming to MCA pattern, we have the proximal, the deep, the main M1 branch and the M2 superior and inferior division. Each will have different types of clinical manifestation and language deficits which can actually modify our plan of management. So what is a natural course in ICAD? It can present as TIA like presentation, we call it usually when it involves a carotid main vessel, it will be presenting as a limb shaking TIA, which will usually be misinterpreted as an acute stroke with seizures, but it may not be actually a seizure pathology. The hand, we call it limb shaking TIA, but it is actually a very a tricky situation, and if not picked up, it can end up in a catastrophic outcome. And another thing is recurrent ischemic stroke. There is a high risk of recurrence within the first 2 years, irrespective of the location of the ICAD. And half of the 50% it will happen within the first month after the first onset of stroke. Sometimes around in 34% it can present as a progressive cognitive decline due to small vessel involvement. So we are all very familiar with this. It used to be fast to improve the sensitivity of pickup. They made it to be fast, and this has actually improved the sensitivity to almost 99% in anterior circulation infarct. B is balance, gait instability, balance and any leg weakness. I is vision disturbances, diplopia. F is face, A facial deviation, A is arm weakness, speech is dysarthria, T is type. So 14% are not recognized with our BFAST evaluation. We are very familiar with the NIHS scoring. One can actually go through in the online forms and you can actually score it. CT aspects in imaging criteria, where we need to decide upon whether the patient can be thrombolized or whether it has to be taken up for mechanical thrombectomy. It is a total point of 10 score in which each region will hold a score of 1, and as the region is involved, 1 point will be deducted from the total score of 10. This is ABCD scoring, which will predict the outcome after a TIA. So, next slide. So this will give you the risk stratification. A score of 0 to 3 has got a low risk, whereas 4 to 5 a moderate risk, and above 4 it has to be they have to be put up on antiplatelet, dual antiplatelets. This scoring was done for predicting the risk of stroke in non-valvular AF. You can go through the scores due to time constraints. I will not be elaborating on this. Next slide. Score 1, we have to think about antithrombotic therapy, either anticoagulation or antiplatelet, but definitely for all score above 2, we need to think about anticoagulation. But while doing anticoagulation, we have to go through the risk of bleeding. So this is the Hasbled criteria. We have Doppler as the first, or I would say that a cheapest investigation, but this is not something which we can plan in the ER. But it will give us an idea on how to manage this cause, all cases after the acute scenarios deal with. So we have a carotid neck vessel Doppler, in which carotid Doppler has got the better sensitivity compared to vertebral Doppler. ICA to common CCA ratio of more than 3 indicates a 60% stenosis, which is quite good as comparable to CT angiography. However, CT angiography is the gold standard for deciding upon further intervention. Transcranial Doppler, which will give us an idea about the intracranial plaque, microemboli, or the reactivity of the blood vessel after an acute stroke. CT angiography, it can detect calcification, the level of narrowing, mild, moderate, severe, or if it's completely occluded, we need to think about carotid revascularization. There is a high resolution MRI which can include vessel wall imaging, which will give us an idea how unstable the plaque is, whether it has got the vulnerability to rupture, intraplaque hemorrhage. Such things can be dealt with an advanced MR imaging. Another thing is penumbral imaging. We need to see the collaterals while we think about taking this case for further imaging, further intervention. So these are the differential diagnosis, acute stroke when a patient lands up in the ER, what all things to be done. So do we have to think about dual antiplatelets? Yes, there is a Sampris trial where they have insisted upon any TIA within 30 days with a symptomatic stenosis of 70 to 99. They have to be put upon dual antiplatelet for at least 90 days. Choice of antiplatelet for all non-hemorrhagic strokes, the norm is we need to start upon aspirin and clopidogrel if thrombolized after 24 hours. These are the different trials, whether they compared whether aspirin alone or clopidogrel alone or a combination. However, they found that some trials were contradictory. There was a chance trial which actually found that dual antithrombotics is the best for most of the large vessel disease, and they came up with newer antiplatelets, ticagrelor, but it was not superior to aspirin or clopidogrel. But combined with aspirin, dual antiplatelets have got a better outcome. There are non-responders. We all know there's something called CYP2C19 mutation who actually don't respond to the conventional dipyridamole antiplatelet. So along with aspirin, we can think about combining newer antiplatelets. So do we have to give anticoagulants for all cases of ICAT? No, there is not. It is not indicated. There is a VASI trial which showed that instead it actually increases the mortality and death. So it is most advisable to go for dual antiplatelet unless there is a coexisting cardiac indication. Statins, yes, 80 milligram statin. However, in Indian population, according to tolerance level, we can taper it down to 40. But the target LDL recommendation is around 65 to 70. Risk factor control, yes, we need a target BP. It is not something which has to be attained over 24 hours. We need to, we should not be reducing the BP to 140/90 over 24 hours, and unless it is a hemorrhagic stroke. And apart from the risk modification, one Sampris trial has focused on physical activity as an important factor in stroke recovery. It actually reduces stroke recurrence by 40%. Next slide. Choice of antihypertensives, there are there were many trials which actually evaluated the usage of ARBs, diuretics. Diuretics, there are not much data, CCBs and beta blockers. We all are very familiar about the perindoperal study, but the thing is, the target of BP drop should not be more than 10% over a day. So the CCBs have got very high potential for rapid BP drop, so as diuretics. So it would be better to resort to ARBs, or at least for acute setting we can go for IV beta blockers if indicated while during thrombolysis. So we all know that what is called permissive hypertension, where the non-perfused artery, it should be brought down to less than 180/100 before administering our thrombolytic agent. And this is for maintaining a reasonable amount of perfusion to the infarcted tissue. And subsequently, after initial management, the BP should be lowered 10% every day, and it should be maintained below 140/90 by the end of 7 to 10 days. Anti-edema measures, there are no studies which show superiority of mannitol or hypertonic saline or one or the other. So you can choose anything according to the patient situation. Of course, you all know where are mannitol and 3% saline are contraindicated. Anticoagulants, yes, in case if we can demonstrate a floating thrombus in the Doppler or in the CT angiogram, one has to be thinking about, and if the patient has landed out of window period, one should think about anticoagulating the patient. And oral anticoagulation after dealing with acute setting, if there are recommendations, as per the AHA recommendation, if there is an AF, irrespective of whether it's persistent or paroxysmal, you have to think about oral anticoagulation. Regarding newer anticoagulants, it is as effective as warfarin, and there are studies which shows rivaroxaban and apixaban and its utility in left atrial enlargement more than 4.6 centimeter. Left ventricular dysfunction, yes, LVEF less than 35% with a target of 2.5 to 3, one has to think about warfarin over antiplatelet. Valvular heart disease, similar mechanism. Yeah, when to start the anticoagulation? So in a risk of high risk hemorrhagic conversion, it is better to delay it for at least 14 days, whereas if the patient has low risk of hemorrhagic conversion, better to start within the first week of thrombolysis. These are the different indications and the types of anticoagulants apart from the current insult, whether the patient has an intraluminal thrombus, whether the patient had a dissection, if there is a cardiac condition coexisting, one has to think about many things while selecting the anticoagulants. Embolic stroke of unknown source, yes, we had different etiologies. After ruling out all the preliminary workup, one need to think about these differentials. So this is a trial which actually focused upon atrial cardiopathy. This is an ongoing trial where they actually focused upon the various biomarkers and then the safety of anticoagulation in such cases. In a patent for amenovil, there is a rope score where they actually give a score for the risk of, do we have to anticoagulate all cases of PFO? So for that we have to determine the score, and then this is the Pascal classification. In a rope score of more than 7, yes, one has to think about anticoagulation in a patent for amenovil. Cancer-related ischemic stroke, yes, embolic stroke of unknown source with high D-dimer, recurrent stroke despite of complaints with anticoagulants, both arterial and venous infarct, and a 3-territory acute infarct, one has to think about cancer-associated ischemic stroke. Next. Dissection, yes, carotid dissections, it is usually in the extracranial ICA, and vertebral artery dissection most often traumatic. There would be history of neck manipulation. Yeah. So ICA dissections are less likely to present with ischemia. They are often presented as a thunderclap headache with an accompanying Horner syndrome, whereas vertebral dissection they will have headache with posterior circulation ischemic stroke. And IVT, in all cases of extracranial dissection, one can think about safely thrombolyze the patient, unlike in an intracranial dissection where there is a high risk for hemorrhagic transformation. So in a CADIS trial, they found that anticoagulants are as equal to dual antiplatelet. On arrival, the main aim should be not to waste time while investigating the patient. Make sure that MRI is not the primary investigation in an acute stroke when he lands up in the window period. Make sure that initial imaging will get over within 20 minutes, and 7% of acute ischemic stroke will be DW negative. And wake-up strokes, one has to resort for MRI to find if there are any DWA flare mismatch. And actually, posterior circulation strokes are highly notorious to turn out to be DWA negative compared to anterior circulation. There can be phenotype mismatch when you feel that, okay, this could be a lacunar. In fact, not necessarily. Even a large vessel disease can present as a lacunar phenotype. Guidelines, the sooner the thrombolysis better, and 2/3 of the patient actually recover within first golden hour. It has got a high likelihood for recanalization in thrombus which are distally located. We are very familiar with contraindication. Two things I want to include is blood sugar control, very important, and aortic arch pathology should be ruled out apart from the conventional contraindications. And any tumors, better to avoid a history of tumor, it is better to avoid thrombolysis. Not contraindicated. When is thrombolysis not contraindicated? So there was an ICAS trial where actually they found that there is it's a common trend that when we see a malignant MCA, in fact, we usually advise the patient to go for mechanical thrombectomy, and if the patient turns out to be not affordable, we usually leave the patient. But there are studies which shows that the reduction in the favorable outcome is not so statistically significant. That means you can still plan for a thrombolysis in a malignant infarct, and age more than 80 years was relaxed, you can still consider thrombolysis. However, the time period is up to 4.5 hours. NIH SITS ISTR registry, high NIH, very bad NIH score of more than 25. There is not much of difference in the parenchymal hematoma formation. Alteplase versus tenecteplase, yes, as sir mentioned, tenecteplase is very good, it is cheap. One should start thinking about switching over to tenecteplase in acute stroke setting. There are adjuvants which are still under trial. Ultrasound mediated breakage of, if it's a long segment thrombus, there are centers abroad which actually incorporate TCD to give signals along after giving TPA, so that it can facilitate the breakage of a thrombus. Outcome, when thrombolyzed within the first hour, it has got 60% recovery. The better the earlier the thrombolysis, the earlier will be the recovery. Endovascular treatment, there are 6 trials which actually shows that even if the patient is a candidate for endovascular treatment, do not delay thrombolysis. We can plan regarding bridge thrombolysis. However, after thrombolysis, one should not delay the procedure for endovascular treatment. It is mechanical thrombectomy. It is like even given within window period, it need not guarantee a full recanalization in proximal vessel occlusion. So for such cases, one should be actually thinking about mechanical thrombectomy with the complete reperfusion target of TC grade 3. There are different trials which actually looked into the time of onset criteria. You can see within 6 hours, 8 hours, 16 and 24 hours. However, the patient should match the criteria as per the trials before taking it up for mechanical thrombectomy. A late window, the maximum permitted hour was a 44 hour in a research trial. So they all, these are criteria we need to look on the aspects criteria, the image which I showed initially, whether it's a large volume infarct, a small volume infarct, what is the penumbra size. We need to think about fitting the patient with any of these trials, so that we can plan regarding mechanical thrombectomy. So severe stroke also, do not delay the initiation of thrombectomy even if the patient has received IV RTPA. Large vessel occlusion, the criteria for large vessel occlusion is MCA, M1, M2 territory, basilar artery and P1 of PCA territory. There is something called ELV, emergent large vessel occlusion. This is a simple screening examination where you can actually see the deviation of the eyes, if the patient can respond to any of our questions. So this is actually meant for preclinical staff who can actually triage the case of acute stroke from the ER to the treatment room, so that no time is wasted in sorting out the case. Yeah. So age more than 80 years is not a contraindication for mechanical thrombectomy. In children more than 18 years, yes, within 6 hours of a large vessel occlusion, one should think about mechanical thrombectomy. In pregnancy, it is upon risk-benefit ratio. If there is there are any chances of uterine bleeding, one should refrain from thrombolizing or doing endovascular therapy. If not, it is still the recommendation for even acute stroke in pregnancy. Stenting versus dual antiplatelet, stenting has got worse outcome. It is not advocated in ICAD. It is still conventional medical management is the treatment of choice. Recurrent stroke, there are various trials which are ongoing, which is yet to come up with biomarkers rather than imaging markers. Role of endarterectomy, yes, when you are getting a case of acute stroke, it is not that we dealt with the current setting. We need to plan for our prevention of recurrent stroke. So one should be planning for endarterectomy if the current insult is associated with the culprit artery, which has got a 70 to 99% stenosis, and it can actually gives a reduction of around 16%. However, when the individuals, the stenosis are less, the recurrence rate is just 4.6%. Then you can still plan for the best medical management. Yeah.
Thank you for the session, ma'am. As a geriatrician and a general practitioner, we usually don't look into these type of data and scoring systems. Whenever the patient reaches, whether we will first identify whether the patient is really having a stroke or not. So how do you differentiate a patient with a stroke and a patient with a metabolic disorders like hypoglycemia or electrolyte disturbances that you have mentioned that be fast? So that is the one thing. And when to intervene the BP. As whenever the patient reaches our OPD, when the patient is having a 180 BP around 10, we usually try to give antihypertensives. So if the patient is an ideal candidate for a thrombolytic therapy, whether we should treat the hypertension or not to treat the hypertension.
Yes, we should treat the hypertension in any cases who lands up during acute stroke and window period of 4.5 hours. The target BP should be brought down to less than 180, 110. And however, the reduction should not be more than 10% every 24 hours. That is the guideline. That's what the guideline says. And further upon, as if at all the patient ends up in a hemorrhagic conversion, then we should target for a mean arterial pressure of 110 millimeter mercury. Mean arterial pressure, not the systolic pressure.
I think stroke is a very huge topic. I think you tried to cover right from the anatomy to the stenting. Actually, for the primary physicians who come here, they should have some certain clear points to take over. The first thing is you should know how to identify your stroke. The basic symptoms you should know and what you should not do. So certain things, now they would change the terminology to brain attack rather than a stroke, to give it as importance as that of a heart attack. So the time is ticking. So what you should not do is never reduce the BP in an acute setting, because you don't know whether it's a ischemic stroke or hemorrhagic stroke. Because the commonest thing people do is to give a sublingual nifedipine. Suddenly the BP drops to 120, 130, the stroke will worsen. So there is no need for any urgency to decrease the BP in an acute setting. See, only if you plan for thrombolysis, you can reduce to 180. Otherwise, even up to 200 is acceptable in an ischemic stroke in an acute setting. Then before knowing the type of stroke, don't give heparin. We have seen people giving heparin on dose and then sending. It's a double-edged. If it is a bleed, it worsens. And if you are given a heparin within 24 hours, we could not thrombolyze. So don't do these two things. That is the major important thing at the primary level. And you should know where to refer. So kindly refer a patient to a center where they have an imaging and a neurologist. Whichever center. There are a lot of centers in Salem. And if the patient is not affordable, at least send them to GH. Even Altiplace is given free of cost in GH. So they have an in-house CT MRI, they have a neurologist, they have Altiplace. Thing is, when to refer, where to refer. That thing you should be able to know. Then rest of the things specialist will take care of. Okay. So with these messages, you should be clear. Don't delay in sending the patient to a scan center. When the patient comes back, it's already over. 4 to 6 hours will be already over. Just send them in an urgent basis to a center where all these facilities are available. Thank you. Thank you, ma'am.
Thank you, sir.
We thank the chairpersons and speakers for the wonderful session. Now the stage is open. Okay. May we request the chairperson to felicitate the speakers with the memento, please. Request the speaker to felicitate the chairperson with the memento. We will move on to the pre-lunch session. It will